Achilles tendon rupture is when the Achilles tendon breaks. The Achilles is the most commonly injured tendon. Rupture can occur while performing actions requiring explosive acceleration, such as pushing off or jumping. The male-to-female ratio for Achilles tendon rupture varies between 7:1 and 4:1 across various studies. Causes: the Achilles tendon is most commonly injured by sudden plantar flexion or dorsiflexion of the ankle, or by forced dorsiflexion of the ankle outside its normal range of motion. Other mechanisms by which the Achilles can be torn involve sudden direct trauma to the tendon, or sudden activation of the Achilles after atrophy from prolonged periods of inactivity. Some other common tears can occur from overuse while participating in intense sports. Twisting or jerking motions can also contribute to injury. Fluoroquinolone antibiotics, famously ciprofloxacin, are known to increase the risk of tendon rupture, particularly Achilles. People who commonly fall victim to Achilles rupture or tear include recreational athletes, people of old age, individuals with previous Achilles tendon tears or ruptures, previous tendon injections or quinolone use, extreme changes in training intensity or activity level, and participation in a new activity. Most cases of Achilles tendon rupture are traumatic sports injuries. The average age of patients is 29–40 years with a male-to-female ratio of nearly 21. Fluoroquinolone antibiotics, such as ciprofloxacin, and glucocorticoids have been linked with an increased risk of Achilles tendon rupture. Direct steroid injections into the tendon have also been linked to rupture. Quinolone has been associated with Achilles tendinitis and Achilles tendon ruptures for some time. Quinolones are antibacterial agents that act at the level of DNA by inhibiting DNA gyrase. DNA gyrase is an enzyme used to unwind double-stranded DNA, which is essential to DNA replication. Quinolone is specialized in the fact that it can attack bacterial DNA and prevent them from replicating by this process, and are frequently prescribed to the elderly. Approximately 2% to 6% of all elderly people over the age of 60 who have had Achilles ruptures can be attributed to the use of quinolones. Anatomy: the Achilles tendon is the strongest and thickest tendon in the body, connecting the gastrocnemius, soleus and plantaris to the calcaneus. It is approximately 15 cm long and begins near the middle portion of the calf. Contraction of the gastrosoleus plantar flexes the foot, enabling such activities as walking, jumping, and running. The Achilles tendon receives its blood supply from its muscular tendinous junction with the triceps surae and its innervation from the sural nerve and to a lesser degree from the tibial nerve. Diagnosis: diagnosis is made by clinical history. Typically people say it feels like being kicked or shot behind the ankle. Upon examination, a gap may be felt just above the heel unless swelling has filled the gap, and the Simmons test will be positive. Squeezing the calf muscles of the affected side while the patient lies prone, face down, with his feet hanging loose results in no movement of the foot, while movement is expected with an intact Achilles tendon and should be observable upon manipulation of the uninvolved calf. Walking will usually be severely impaired, as the patient will be unable to step off the ground using the injured leg. The patient will also be unable to stand up on the toes of that leg, and pointing the foot downward will be impaired. Pain may be severe, and swelling is common. Sometimes an ultrasound scan may be required to clarify or confirm the diagnosis. MRI can also be used to confirm the diagnosis. Imaging musculoskeletal ultrasonography can be used to determine the tendon thickness, character, and presence of a tear. It works by sending extremely high frequencies of sound through the body. Some of these sounds are reflected back off the spaces between interstitial fluid and soft tissue or bone. These reflected images can be analyzed and computed into an image. These images are captured in real time and can be very helpful in detecting movement of the tendon and visualizing possible injuries or tears. This device makes it very easy to spot structural damages to soft tissues, and consistent method of detecting this type of injury. This imaging modality is inexpensive, involves no ionizing radiation and, in the hands of skilled ultrasonographers, may be very reliable. Magnetic resonance imaging can be used to discern incomplete ruptures from degeneration of the Achilles tendon, and MRI can also distinguish between peritendinitis, tendinosis, and bursitis. This technique uses a strong uniform magnetic field to align millions of protons running through the body. These protons are then bombarded with radio waves that knock some of them out of alignment. When these protons return, they emit their own unique radio waves that can be analyzed by a computer in 3D to create sharp cross-sectional image of the area of interest. MRI can provide unparalleled contrast in soft tissue for an extremely high-quality photograph, making it easy for technicians to spot tears and other injuries. Radiography can also be used to indirectly identify Achilles tears. Radiography uses X-rays to analyze the point of injury. This is not very effective at identifying injuries to soft tissue. X-rays are created when high-energy electrons hit a metal source. X-ray images are required by utilizing the different attenuation characteristics of dense and less dense tissues when these rays pass through tissue and are captured on film. X-rays are generally exposed to optimize visualization of dense objects such as bone, while soft tissue remains relatively undifferentiated in the background. Radiography has little role in assessment of Achilles tendon injury and is more useful for ruling out other injuries such as calcaneal fractures. Treatment. Treatment options for an Achilles tendon rupture include surgical and non-surgical approaches. Among the medical profession, opinions are divided what is to be preferred. Non-surgical management traditionally was selected for minor ruptures, less active patients, and those with medical conditions that prevent them from undergoing surgery. It traditionally consisted of restriction in a plaster cast for 6 to 8 weeks with the foot pointed downwards. But recent studies have produced superior results with much more rapid rehabilitation in fixed or hinged boots. Some surgeons feel an early surgical repair of the tendon is beneficial. The surgical option was long thought to offer a significantly smaller risk of re-rupture compared to traditional non-operative management. Of course, surgery imposes higher relative risks of perioperative mortality and morbidity, for example infection including MRSA, bleeding, deep vein thrombosis, lingering anesthesia effects, etc. However, 4 recent studies have scientifically tested the benefits of surgery, using randomized streaming of patients into surgical and non-surgical protocols, and applying virtually identical rehabilitation protocols to both types of patients. All 4 such studies completed to date have found only small, but statistically significant benefits from the surgery, separated from the other confounding variables. They have all produced reasonably comparable results in re-rupture rates, strength, and range of motion, while most have reaffirmed the greater complication rate from surgery. 2 studies showed small, but statistically significant differences in plantar flexion strength. The surgical group had significantly better results in the heel rise work, heel rise height, concentric power, and hopping tests at the 6-month evaluation than did the non-surgical group. However, at the 12-month evaluation, there was a significant between groups difference only in the heel rise work test. The relative benefits of surgical and non-surgical treatments remains a subject of debate. Authors of studies are cautious about the preferred treatment. It should be noted that in centers that do not have early range of motion rehabilitation available, surgical repair is preferred to decrease re-rupture rates. Surgery. There are 2 different types of surgeries. Open surgery and percutaneous surgery. During an open surgery, an incision is made in the back of the leg and the Achilles tendon is stitched together. In a complete or serious rupture, the tendon of plantaris or another vestigial muscle is harvested and wrapped around the Achilles tendon, increasing the strength of the repaired tendon. If the tissue quality is poor, for example the injury has been neglected, the surgeon might use a reinforcement mesh. In percutaneous surgery, the surgeon makes several small incisions, rather than one large incision, and sews the tendon back together through the incision. Surgery may be delayed for about a week after the rupture to let the swelling go down. For sedentary patients and those who have vasculopathy or risks for poor healing, percutaneous surgical repair may be a better treatment choice than open surgical repair. Rehabilitation. Non-surgical treatment used to involve very long periods in a series of casts, and took longer to complete than surgical treatment. But both surgical and non-surgical rehabilitation protocols have recently become quicker, shorter, more aggressive, and more successful. It used to be that patients who underwent surgery would wear a cast for approximately 4 to 8 weeks after surgery and were only allowed to gently move the ankle once out of the cast. Recent studies have shown that patients have quicker and more successful recoveries when they are allowed to move and lightly stretch their ankle immediately after surgery. To keep their ankles safe, these patients use a removable boot while walking and doing daily activities. Modern studies including non-surgical patients generally limit non-weight bearing to 2 weeks, and use modern removable boots either fixed or hinged, rather than casts. Physiotherapy is often begun as early as 2 weeks following the start of either kind of treatment. There are 3 things that need to be kept in mind while rehabilitating a ruptured Achilles: range of motion, functional strength, and sometimes orthotic support. Range of motion is important because it takes into mind the tightness of the repaired tendon. When beginning rehab, a patient should perform stretches lightly and increase the intensity as time and pain permits. Putting linear stress on the tendon is important because it stimulates connective tissue repair, which can be achieved while performing the Euro stretch, Euro. Doing stretches to gain functional strength are also important because it improves healing in the tendon, which will in turn lead to a quicker return to activities. These stretches should be more intense and should involve some sort of weight bearing, which helps reorient and strengthen the collagen fibers in the injured ankle. A popular stretch used for this phase of rehabilitation is the toe raise on an elevated surface. The patient is to push up onto the toes and lower his or herself as far down as possible and repeat several times. The other part of the rehab process is orthotic support. This does not Euro unregistered trademark T have anything to do with stretching or strengthening the tendon, rather it is in place to keep the patient comfortable. These are custom-made inserts that fit into the patient's shoe and help with proper pronation of the foot, which is otherwise a problem that can lead to problems with the Achilles. To briefly summarize the steps of rehabilitating a ruptured Achilles tendon, you should begin with range of motion type stretching. This will allow the ankle to get used to moving again and get ready for weight-bearing activities. Then there is functional strength. This is where weight bearing should begin in order to start strengthening the tendon and getting it ready to perform daily activities and eventually in athletic situations. References. External links: image sequence demonstrating Achilles tendinosis and Achilles tendon rupture.